Gives me great pleasure to invite Dr. Sri Ganesh, who needs no introduction. He's the most prolific cataract and refractive surgeon of our country with international and national repute. And he's going to be talking about hyperopic smile and Visumex 800.
Thank you, Doctor.
I think that's his forte.
She is basically the mother of smile, who actually first introduced smile in India and internationally. I have changed my topic because I don't do much of surface ablation, because in the program it says surface ablation, but I hardly do surface ablation. So I would be talking on an interesting topic which we have been involved in, which is hyperopic smile. I am a consultant to Carl Zeiss Meditech. So the initial lenticule profile for hyperopic flex, and this study was performed by Walter Secondo, where they did a feasibility study on 9 eyes, and they used a transition zone of 1 millimeters. 1 millimeter, and the minimum thickness was 25 microns in the center. So this was the profile where it is thinner in the center and thicker in the mid periphery, and you remove more tissue in the mid periphery, similar to how you do with LASIK. And with their hyperopic flex, the predictability was 70% within half a diopter and 89-90% within one diopter. So there was also, they found that there was quite a bit of regression because the transition zone was just 1 millimeter, and this was published in 2018. The Nepal hyperopic smile study, which used larger optical zones and transition zones, they used an average of 6.5 millimeters zone, and they treated a mean spherical equivalent of plus 5.73, which is fairly moderate to high hyperopia, and it was a younger population. And they published their results in the Journal of Refractive Surgery, which showed that they achieved good centration, and 6.3 mm zone with smile corresponds to a 7 mm zone with LASIK. So you get relatively larger zones with hyperopic smile than LASIK, and so better stability. And this was the first multicentric approval study, which is finished and submitted for CE approval. And there were 8 investigators from all over the world, and the principal investigator was Walter Secondo. And our hospital was one of the sites for the global trials for hyperopia. So in this multicentric trial, we used a M size pack. You can't use an S pack because you have a larger ablation zone. The white to white had to be more than 11.5 millimeters. We used an optical zone of 6.3 mm, a transition zone of 2 millimeters. Central thickness was 25 microns, and the cap was 8.8 to 8.9 mm, and we used a 120 micron cap, and we used an incision of 2 to 4 millimeters, and we used lower energies. The average energies in the centers were between 26 to 27. Inclusion criteria were patients with hyperopia or hyperopia with astigmatism, and the predicted post-op K should be less than 51 diopters. Pre-op corrected vision 20-25 or better in each eye treated. And we treated a total of 374 eyes, 199 patients, average age of 38.8 years, and almost equal distribution of the gender. Attempted hyperopic sphere correction was plus 2.76, but the range was 0.25 to 6 diopters. Attempted refractive cylinder was 0.88 to 0.87 on an average, but the range was 0 to 4.75, and spherical equivalent attempted was 3.20, and the preoperative minimum corneal thickness was 544, and the pupil size on an average was 4.9. So if you look at the safety, again in total 9 visits were required, and these patients were followed up for 12 months. If you look at the safety index distribution, immediate post-op, there is a little less in the safety index, but at 12 months the safety index was at 1, which is quite good. If you look at the contrast sensitivity, again there is a little bit of drop in the contrast sensitivity when compared to the pre-op but still it is within the normal range. Coming to the efficacy, you can see that 88% of the eyes had visual acuity of uncorrected visual acuity of 20/25 or better. So that is quite good for hyperopia. And 68% 20/20, 6/6. The safety, if you look at it, 77%, there was no change in the best corrected vision. 11% lost one line and 1.2% lost two lines. And about 10% had actually a gain in one line. This is the predictability, which is the spherical equivalent attempted versus achieved, and you can look at the scatter, and most of the eyes were within one diopter almost, but there were some outliers. And if you look at the post-op spherical equivalent refraction, 81% were within half a diopter, which is good for hyperopia, and 93% within one diopter. And we found that there was increasing undercorrection over plus 3 diopters of hyperopia, so we need further nomogram adjustments. If you look at the stability over 12 months, you can see that only 9% had a change of more than half a diopter. So even after 9 months, there is some amount of small regression, probably because of the late epithelial healing, but what we found that the stability is quite good. It stabilizes by about 2 months, 3 months, and then it is fairly stable with slight regression, late regression. The stability, in fact, when you compare it to LASIK, is better with SMILE. If you look at the astigmatic correction, 75% of the eyes were within half a diopter and 93% within one diopter. And even patients with over one diopter cylinder were well corrected. So basically, the results of the global multicentric trial were much better than the previous hyperopic flex and the Nepal SMILE studies. Marginally better refractive outcomes than the hyperopic femto LASIK with MEL 90, which had 73% within half a diopter and 93% within one diopter. There was a higher incidence of a transient haze compared to myopic SMILE. So with hyperopia, you have larger zones, and we found that the haze was slightly less, but it was transient. And the recovery is slightly slower compared to a femto LASIK for hyperopia. But what we found is there is less regression in hyperopic SMILE than hyperopic LASIK. So the CE approval for SMILE should happen anytime within the next 1.5 months. And what we learned from the study is that you will have to use an M-size pack. And sometimes you have smaller white to white in hyperopic eyes, which is difficult to treat because the ablation goes up to the limbus, and it can be difficult to dissect. Longer treatment times with the 500, almost 35 seconds. Suction rate loss for hyperopic SMILE was 0.7 when compared to myopic SMILE, which was 0.3. The suction loss in the multicentric trial was 1.34%. With the Visumax 800, it is 3 times faster, and you also have tracking for centration and cyclotorsion. So the results will be better, and they're going to make the hyperopic SMILE available only on the Visumax 800, and it should be available commercially in the next 3-4 months. So to conclude, integration of hyperopic SMILE into the new Visumax 800 will provide an excellent option for laser vision correction of hyperopia and hyperopic astigmatism, and this we should see in the next 3 to 6 months. Thank you very much for your attention.
Excellent talk, Dr. C. Ganesh, sir. Sir, like you're talking about the hyperopic SMILE. I think initially what I know that you started the study with the Visumax 500 for hyperopic SMILE. But that what you are showing about the time, that is around 34 seconds. Even with the Visumax 800 also the time is same for hyperopic?
No, for hyperopic it will be within about 18 seconds.
18 seconds. So only with the Visumax 500 it was around 34 seconds. So chances of suction loss was quite high, like 1:150. That's what you are showing.
So that's why the company has decided to make it available only on the 800 and not the 500. Yeah. The hyperopic SMILE.
Would you suggest to do in any hyperopic cases done on the cornea, an extra procedure to have better stability over a period
Yeah, for
of time?
younger patients, we prefer, because younger patients, regression is more because of the epithelial hyperplasia and also the corneal biomechanics. In SMILE, the corneal biomechanics are better than LASIK, so that's why we see less regression. But if you add a cross-linking, then probably it will be that late regression will be less. And so we probably need to do studies where we combine cross-linking with in hyperopic SMILE, and look at the long-term results, especially in young patients.
And which refraction are you considering when you're treating hyperopia?
Pardon?
Which refraction? Is it the dilated manifest refraction?
We look at the dilated.
And which cyclopegia do you use?
We always do a cycloplegic refraction because many of these young patients accommodate, and there is a nomogram.
So which cyclopegia do you use?
We
So
use cyclopentolate.
Cyclopentolate.
We use cyclopentolate because in the younger patients, it's very important to paralyze the accommodation. Otherwise, again, you can have undercorrection if you don't do that.
And do you use the full cycloplegic refraction even in younger patients, or do you tend to undercorrect slightly? Or
no, we use, actually there is a nomogram which actually overcorrects because of the regression. But even using that nomogram, they found that there is some amount of late regression. So what happens is, when we, in these young patients, when we use the nomogram, initially we see that they are a little overcorrected, but by about 3 months they kind of stabilize.
so that's a very important take-home point, that in hyperopic correction, you do initially expect that the accommodation will take some time to relax. So if they are overcorrected or apparently overcorrected, you should not get scared, and you should
So
wait
many of these patients,
at least for 3 months.
many of these patients, immediate post-op, they say that distance vision is blur. They keep complaining that the near vision is better, but the distance vision is blur.
They may sometimes accept
And
even
you just need
-2 or something.
Yeah, you just need to reassure them, and there's more chair time. Tell them that by about 3 months it settles down, and it will eventually settle down.
But do attempt a full cycloplegic correction.
Thank you, sir. Thank you for the excellent.